All right. Welcome to Drug Trends in the Great Lakes Region. What are they? And how do we address them? With Josh Esrick and Aaron Ficker. This presentation was prepared for the Great Lakes PTTC under a cooperative agreement from the Substance Abuse and Mental Health Services Administration, or SAMHSA. The opinions expressed in this webinar are the views of the speakers and do not reflect the official position of the Department of Health and Human Services. The PTTC believes that words matter and uses affirming language in all activities. We want to thank you again for joining us and share a few housekeeping items. If you have technical issues, please individually message me, Rebecca Buller, in the chat at the bottom of your screen, and I'll be happy to assist you. If captions or live transcript would be helpful, please use your Zoom toolbar to enable by selecting live transcript. If you have questions for our speaker, please put any questions in the Q&A section, which is also at the bottom of your screen. You will be directed to a short survey link after this session, and we would appreciate it if you could fill it out. It takes just about 3 minutes, and it helps us report to our funders and to improve the training offerings that we present. Finally, if certificates of attendance will be sent out via email to all those who attended this webinar in full, and it can take up to 2 weeks to receive those certificates. One other note, I want to let you know that we will be following up with an email to everyone sent tomorrow with the slides and any unanswered questions that might come up during the webinar. If you'd like to know more about what we're doing or information on upcoming events, please see our social media pages. And now I'd like to introduce our presenters. Josh Esrick is the Chief of Training and Technical Assistance at Carnival Associates. Mr. Esrick has over 10 years of experience researching, writing, evaluating, and presenting on substance use prevention and other behavioral health topics, and in many cases for SAMHSA PTTCs. Aaron Ficker serves as the Prevention Manager for the Great Lakes PTTC, and for more than 16 years, Aaron has worked in the substance abuse prevention, supporting communities to use evidence-based strategies and data-driven processes in substance abuse prevention planning and implementation. And now I'm going to turn things over to Josh and Aaron.
Hi, everyone. Thank you so much for being here today. We're excited to have so many of you in the room with us. And I am going to just pull up my slides. Thank you so much. So we are identifying and addressing emerging trends in the Great Lake region, and we're absolutely delighted and honored to have Josh, who's just an expert in the field and has been doing this work for a long time. So thank you, Josh, for being with us today. Great, and there are people from all over the country, including the Great Lakes. We are focusing on the Great Lakes, just as a note. This may seem like straightforward, but there's a lot in between here and there. So I just want to remind everyone, like, we're going to get to where we're going. It might just take a minute. And remember that we're going to take some turns along the way. Our objectives today are to discuss the context in which we consider these changes in substance use trends. As things change and evolve, what context do we want to look at those changes in? We're going to list 4 ways that changing trends impacts our work. How does that impact what we're doing? We're also going to explain the importance of incorporating emerging trends into our ongoing strategic planning and the work that we've been doing. And we'll review the emerging trends in drug use for regions 5 and compare those with national numbers. Josh and I are going to go through and he's going to present a whole bunch of data, and we'll have some time for discussion and questions kind of at the end of each section. But we want to start with this kind of thinking about when we consider addressing emerging trends, we want to ask some questions, and we want to make sure we're looking at those trends in the context of our work. So we want to ask questions like, why do we care? Why should we look at this trend data? At why is this important, and why are we looking at it now? What can we learn? what information can we learn about our communities and about drug use trends and about where things are going by looking at this data? We also want to ask what impact there is on our existing work. So again, keeping in mind that thinking about this in the context of our existing work and our existing strategic planning processes, how does that impact our work, change or maybe not change the work that we're doing? And how are we going to move forward with addressing this issue? Now that we have this information, what are we going to do with it? How do we include that in our work? How do we address that directly? So we're going to start there and focus on what that context is. I'm going to turn it over to Josh to explain to us why we care, what we can learn, and how it's going to impact our work, and then we're going to address it.
Sounds good. Thanks, Aaron. Hi, everyone. Want to also thank you all for joining us today. So first of all, like Aaron said, I'm going to go through those questions that she raised, beginning with, why do we care about emerging trends? Why should we look for them? And the real simple answer is because emerging trends give us an indication of what will happen in the future. Sometimes with trends, the numbers that we're talking about in terms of prevalence rates or in terms of consequences can be pretty low, but that doesn't mean there always will be low. For instance, if we were doing this, well, we didn't have webinars back in the early 90s, but if we were doing a presentation on emerging trends in the early 90s and we're talking about prescription opioid misuse, the numbers would have been pretty low, but they would have been starting to go up already. That was an emerging trend, which we didn't really recognize at the time because there wasn't as much, attention being paid to epidemiological surveillance back then. This chart that you see on the slide here is meant to visualize this concept a bit. It illustrates what research has identified as sort of the three core stages of a substance use epidemic, where in stage one, there's primarily initiation or experimentation with the substance. Then in stage two, there starts to be more and more prevalence of the substance, becomes a bit more obvious in the data what's going on. And then in stage three, there starts to be widespread substance use disorders. And the idea behind the two arrows on here is, we want to be, if we can, addressing trends way back at the beginning when we're still in that initiation and experimentation stage. We don't want to be waiting until there's already widespread substance use disorders. We always talk about in the field, a dollar of prevention saves, X number of dollars of treatment. The exact number of X, varies by study, but it's generally agreed, right? Prevention is extremely cost effective. But that only really happens if we can get out ahead of things. And so that's why we really want to look for emerging trends and begin addressing them when we see them. So what can we learn about emerging trends? Well, there's a lot of different data that can exist out there, like how widespread is the substance? What are the consequences that stem from it? What are the risk and protective factors that are leading to that substance use, including those really core root causes and things like the social determinants of health. What are the specific populations being impacted? Sometimes an emerging trend might not be a new substance at all. It's just the use is beginning to occur in a population where it previously hadn't been. And also, what is the environmental context around this use? Things like the general community attitudes and norms, laws, regulations, so on and so forth. We're not going to be able to cover all of this data for all of these substances today. That wouldn't be a webinar. That would be like a whole conference. So this presentation is really meant to be a starting point. But if you are really interested in what the emerging trends are in your community or in your state, it is important that you conduct your own needs assessment and really get information on all of these different pieces. And through learning this information, we can start to learn how it impacts our work. And there's really four main ways that it can, which you see on the screen here. And we'll go through each of these in turn over the next four slides. So the first one is, how it might change our priorities. In prevention, we unfortunately do have limited resources. We can't always address every issue at all times rather. So we have to figure out how to balance emerging trends that we find versus sort of the ongoing issues that we've been addressing for a long time versus trying to address just the underlying needs of the community. Maybe trying to make some sort of policy change that will address multiple different substances, but that will take a long time to move forward. And through obtaining emerging trend data, we can have more information to figure out how our priorities might shift, or potentially learn that our priorities don't need to shift. Sometimes we might decide that an emerging trend isn't actually a major issue, or we might discover that the best way to address this trend is actually through continuing the work that we're already doing. We really don't want to just play whack-a-mole, constantly shifting from one emerging trend to the next. So it really is important to figure out, what are the priorities here. The second one is figuring out if we need to make any changes in the partners we're working with. For instance, if through the emerging trend data that we look at, we find that there is a new population that is suffering from some form of substance misuse that we want to better address, and we haven't really served that population before, we need to start figuring out, well, who are the community organizations that we can work with to better serve that population? And maybe those organizations we've already worked with on other issues, but maybe they're brand new, in which case, we have to go through the whole, building up collaborations process, building up partnerships. And obviously there's a lot of resources that exist from SAMHSA to talk all about that process. The third way it can impact us is it might lead us to needing to revisit our strategic plan, where we actually start figuring out, is the work that we're currently doing capable of addressing these emerging trends? If not, are there new things we should be implementing to address them? And if that's the case, do we have the capacity to implement them? As with all forms of whatever we're doing in prevention, we really want to be really thinking through strategically how we address an emerging trend. We don't just want to say, oh, there's this new trend, let's do X. It really is important that we figure out how addressing it might fit into our overall strategic plan that we're trying to follow. And so, as I sort of mentioned, lastly, through that strategic planning, you might discover that you need to adjust what you exactly are doing. Maybe you do need to implement new programs and strategies, and maybe it's so important that you address this new trend that you actually, because you have limited capacity, need to replace an existing strategy with those new ones. Alternatively, maybe you'll be able to do both, or even you'll find that what you're already doing is in fact the best way of addressing this emerging trend already. And so all we would want to do is try to just expand the reach and capacity of that existing strategy to better address the emerging trend. It's really, a lot more can be said about this, but I just wanted to spend these first few slides raising the points that you need to think through before you actually start addressing emerging trends. And so with that said, let's start diving into what these trends actually are, what the data is showing us. And as Aaron said, we're going to be specifically talking about what's going on in Region 5 / the Great Lakes region, with just some comparisons to national data. And we're going to start by talking about, well, not a new substance, but what's the latest going on with one that I think we're all pretty familiar with, which is alcohol. Beginning with underage alcohol use. So this chart here shows what's been going on with past month underage alcohol use for the past 5 years nationally. If you're not familiar with the term past month, it refers to people who've used a substance, in this case alcohol, at least once in the past month, which is generally considered current use. And also, when we're talking about underage, we're usually looking at data that mean 12 to 20-year-olds. There usually isn't really data on those under 12. And this, as well as most data that we're going through today, comes from the National Survey on Drug Use and Health, which is a SAMHSA-funded survey. But for all of our slides, we have the source on the bottom of the screen there. And when we look at underage alcohol use, what we see is actually an ongoing downward trend in how many youth are using alcohol. And this trend actually goes all the way back to at least 1990s. There's another survey that has data going back that far called Monitoring the Future. And Monitoring the Future estimates that back in 1991, the past month underage alcohol use was about 40%. So for about 3 decades now, we've been seeing some pretty strong successes in reducing underage alcohol use. Now, that being said, do look at, the y-axis there and what the numbers are, showing that about 15% of youth are still engaged in regular alcohol use. And that is a high number compared to some of the other substances we'll be talking about over the course of this presentation. So, alcohol is one of those topics where, yes, we are having success, but it's still, one of the biggest issues to address. But because we have been having success, we do know a fair amount of best practices for preventing underage alcohol use. It's also worth noting that there was that little bump up in the 2019/2020 combined data, which does stem from the impact of COVID-19. And there has been a fair amount of research showing how, the impact of COVID may have influenced, youth alcohol use, particularly easier accessibility to it. So then on this slide, we can see how the different states in the region compare to the national data. And I'm just going to click through them, but you'll see generally, all the states of the region, so Illinois, Indiana, Michigan, Minnesota, Ohio, and Wisconsin, are pretty much all following the same trend line as the national data. Maybe the numbers are slightly higher or slightly lower, but they're pretty clustered together, and pretty much every state is following those national trends. There's no, major outliers in terms of what's going on. But it's not only underage alcohol use that we're concerned about when we talk about alcohol. We're also concerned with binge alcohol use, which is defined as having 5 or more drinks in one sitting. This chart here shows the national numbers, and again, you see there is a general downward trend, but the number is still, over 20%, which does make it one of the most common forms of substance misuse. So it remains an issue that we are concerned about. And when we look at the state numbers, we again see that, the states are all pretty much following the national data. And I also want to note, like, when we are looking at state data, sometimes the data is a little bit noisy because the samples are a bit smaller. So if you see one state acting a little bit differently than all the others, it's certainly worth investigating further, but it doesn't actually necessarily mean that there's something different going on in that state. It could just be an issue with the sample. So anytime, if you're looking at your own state and you see, why are we so different from other states, especially why are we so different in just 1 year, it's worth looking into further, because it might actually just be an issue in the data and not represent something. So successes in alcohol, right? Well, we are seeing some, although as I mentioned, the numbers are still higher than we'd like. But then we talk about alcohol-induced deaths. And you can see, well, we made this chart instead of a graph. And you can see that over the past 5 years, both nationally and in all the states in the region, there's been a very large increase actually in alcohol-induced deaths. So a couple notes here. First of all, this data, as well as all death data that we talk about today, is being presented as what's called the per 100,000 people number. So the way to read this, for instance, is that in 2017, nationally, out of every 100,000 people, 11 of them died of an alcohol-induced cause. And that way we can normalize for differences in population. Like obviously Ohio has a much smaller population than the nation, but using this per 100,000 number, we can make a direct comparison. Also, when we're talking about an alcohol-induced cause of death, or a death with an alcohol-induced cause, it means that the coroner or medical examiner, depending on how the state does things, determined that alcohol was one of the underlying causes of death. So it excludes deaths where maybe someone had alcohol in their system, but it's not relevant to why they died. But it includes people who died from something stemming from alcohol, even if alcohol wasn't currently in their system. For instance, if someone died from liver cirrhosis, that's determined to have stemmed from their alcohol consumption, even if they don't have alcohol in their system at the time, they're counted in this number. So this isn't just alcohol poisonings. This shows us that even if the overall numbers for things like binge drinking are getting better, there's clearly a lot of work that we still need to do so we can get a handle on these increases in deaths. In terms of why these different issues are occurring, one of the big risk factors for any form of substance misuse is the perception of great risk of harm. So this data here shows that number for alcohol. This is specifically the percentage of people who said they perceived a great risk of harm from consuming 5 or more drinks, which is the definition of binge drinking, at least 1 or 2 times in a week. And you can see that the numbers are from 2017 to 2021 are basically flat, or in some cases have even increased a bit, which is noteworthy because, as you'll see with some of the other perceptions of harm we'll talk about today, a lot of them have been going down, and they haven't with alcohol. And also with alcohol, we actually are seeing those use numbers go down. It's unknown if there's a direct causal connection between this maintenance of the perceptions of harm and why there's been a continued improvement in binge drinking and underage use, but it is certainly at least notable and a thing we want to pay attention to. There are a lot of other risk factors that are known to be really important causes of alcohol misuse, and so we have some of them listed here. So for instance, an earlier age of alcohol initiation. Research has found that people who start using alcohol, even just rarely, before age 15 are 6 times more likely to develop alcohol dependency compared to those who start using after they're over 21. There's a lot of research showing how school engagement and early educational success is a strong protective factor against alcohol use among youth. So a lack of school engagement is a pretty important risk factor. Likewise, if there's not that peer or parental disapproval of alcohol use, that's pretty strongly correlated with an increased risk of use. Accessibility is also very important one, and we actually see a decline there. So for instance, among 10th graders back in 2017, 62.5% reported that they thought there was easy access to alcohol. And by 2023, that was down to 48.3%. So that's a huge reduction in accessibility just in the past 6 years, which might also be contributing to the continued decrease in underage use. Another risk factor is the risk from positive perceptions. The issue, which is particularly noticeable among college age youth, where people, due to various reasons, believe that alcohol will have various benefits for them, and so they become more likely to consume alcohol. And lastly, it's maybe not just an issue around alcohol, potentially all forms of substance use, this impact from reduced access to prevention services. So to put some numbers to what we mean by that, from 2016 to 2022, the percent of youth who participated in a prevention program outside of their school declined from 11.4% to 6.3%. And the number who saw any prevention message outside of their school declined from 72.7% to 62.5%. So there's been a fair amount of talk about how there was this lack of access to prevention, as well as all sorts of social services during the lockdowns of COVID-19. But this decline in prevention in seeing messages and participating in prevention programs stretches at least as far back as 2016, and really speaks to the need to sort of increase investments in prevention. So that's sort of the data we have on alcohol. So, Erin?
Great. Thank you. That was a lot of important information, and some of it, some of it surprising and some of it exciting. But we really are curious from you, and if you want to throw a question in the Q&A, feel free to. If you have a question for Josh as it relates to the alcohol questions around what does it mean for prevention, does this match what you're seeing? You can put that in the chat. If you have a question specifically, you can add it to the Q&A. And does this change your thinking about your existing work, and what other information might you need? So those are some of the questions we want to be thinking about. But Josh, I have a question for you about the relationship between those trends in alcohol misuse that you showed us, and the deaths. To me, I'm not sure how that lines up, and so I'm curious if you could say more about that.
Yeah, no, it's a really important point there, and we know a few things that are going on. First of all, we know that the severity of alcohol use among people who already were binge drinking increased quite a bit during the pandemic. People who already were drinking heavily, increasing their consumption to cope with stress, from the pandemic, and that increase in consumption likely increased the risk that, there'd be more severe consequences from their use. There's also research showing that, the COVID-19 pandemic had other impacts, like causing people to be less likely to seek medical care, including for, things like liver disease. And again, the alcohol-induced causes do include that kind of data. And then lastly, there is the issue that there's a pretty well, there's a relationship between alcohol consumption and risk of suicide. About 20% of suicide deaths involve alcohol. And while we're not really talking about suicide too much today, there has been a very noticeable increase in suicide deaths over the past 20 years. And sort of as that's been increasing, and I said about 20% of those deaths involve alcohol, that can just lead to an increase in those deaths as well.
Oh, well, that all adds up now that you put it into that context. That's helpful to understand that increase in use from those already using makes a lot of sense. Thank you for that. And then the other thing that I heard there that I found really interesting is the change in the amount of prevention happening in outside of school time for youth. And that's just fascinating as we think. And I don't know if it's a question or more of just my thinking, as it really helps us think about what does this mean for the work that we're doing, and has that happened? So are other people seeing that happen in their communities, or are we seeing that in the data in your community? So we did get a couple comments that looks like this does match your experience. So we can keep going, and I learn more about our next topic if there aren't any specific questions. Oh, so the question was data specific to after school prevention program, or did it just include in school prevention? So that's kind of an interesting question, right? So is after school programming considered related to school time?
Yeah, no, that is a good question. And honestly, I will have to go back to that data comes from NISDA and look again at how they're defining it, because I don't remember off the top of my head if after school counts as part of school or not. So we will get back to you on that, and that'll be one of those answers we include in the email that will go out later.
Right. And I love the way that you're thinking, right? Because that really does impact how we would move forward with making any adjustments to our prevention, is understanding that specific piece of data a little bit more. Well, I'm going to suggest that we keep moving, because the next topic that we're going to talk about, I think it's really interesting, important, and ever changing for a lot of us. So we're going to talk next about cannabis. And so I'm going to turn it over to Josh to talk a little bit about that. Wait, before we do that though, I do have, I'm going to take a minute. We'll come back to this question in a little bit. So go ahead and let's get started on cannabis.
Okay. Yeah, so with cannabis, first of all, let's just look at what the number is nationally. This is not across youth, or this is just everyone 12 and older. You can see, sort of in contrast to alcohol, an ongoing upwards trend. And you can also see that if you look at the y-axis, the numbers are, we're talking about a slightly smaller number than alcohol, but not actually that much. 13% of youth, not youth, of adults, or everyone rather, consume cannabis currently past month by 2021. So, it is sort of a contrast, just first of all. And we can also see, when we look at the states in the region, that pretty much all of them show increases as well. Now, a thing I do want to note here about this is that, the two states in the Great Lakes region who currently do not have legalized adult / non-medical / recreational, whatever term you're most familiar with, the two states that do not have that legalized do have the smallest increases over this period of time we're showing here. But this most recent data, you can see, is actually still from 2021. And at that time, only 2 of the other 4 states actually legalized so far. And also, they'd only recently legalized. And the increase stretches all the way back, to 2017, 2018. This is why there's actually an ongoing debate about to what extent does, and this is jumping ahead talking about risk factors a little bit, but to what extent is legalization itself responsible for increases in use versus simply the debate about legalization being responsible because that leads to a normalization of use and sort of starts making it, impacting the risk factors against it. If we're starting to talk about, well, why shouldn't it be legal, then it starts leading to more people being potentially more likely to use it, even if it hasn't been legalized. So it's something we, need to learn more about, but are trying to, keep track of. Now, when we do talk about cannabis use, obviously a lot of focus is on what's going on among youth, and that's because the research does show that cannabis use, particularly before age 25, does have impacts on brain development. So we're particularly concerned about the harms there. And what you see when you look at the data, specifically for 2021, you can see that youth use, so defining those under 18, actually is relatively low. And in fact, even though I don't have the trend lines on the slide here, looking at the Great Lakes region, in 3 states from 2017 to 2021, there were actually declines in that youth use. And in the other 3, there were increases, but they weren't that large compared to the increases in some of the older age groups. 18 to 25-year-olds do have the highest rates of use, as you can see. And actually, if you further divide that into sort of 18 to 20-year-olds and then 21 to 25, in other words, getting to see the difference between those who could legally consume cannabis in states that have legalized it versus those that haven't, the number's higher in the 21 to 25-year-olds. So like nationally, you can see that overall it's at 24.1%, but among 18 to 20-year-olds, it's 20%. And then among 21 to 25-year-olds, it's 26.8%. And then among likewise, if you look at 26 and older, there's sort of a split as well. Although in that case, it's the people younger in that group have higher rates. So like 26 to 49-year-olds, use is a lot higher than among those 50 and older. Interestingly, though, even though the use is highest among those 18 to 25-year-olds, the largest increase in use in recent years has been among adults, those 26 and older. That's where we've been seeing the largest increases in cannabis use over the past several years. So one of the big risk factors, again, as I mentioned with alcohol, is that perception of great risk of harm. And you can see some pretty big declines, with one exception. And I don't know enough about Wisconsin to know exactly why they're bucking that trend there. But pretty much nationally, as well as in every other state, you can see these declines in the perception of great risk of cannabis use. And also, I want to note that this chart is on a different scale than alcohol. The x-axis, with alcohol, we were going up to 50%. This one only goes up to 30%. So you can see, like in the middle of the chart there, we're only seeing that like 15% of people were perceiving a great risk of harm from cannabis use. And that declining perception of harm may be linked, to a lot of things, but including that debate around legalization. People can start thinking, well, if we're going to legalize it, there must not be any risk there. And so, the perceptions go down. And speaking of legalization, it is worth noting just how much it has expanded in recent years. So this map here is one that I actually put together back in 2020, right before the election. And it was meant to illustrate, what's going on and what might go on with ballot initiatives. But the main thing to note is the really dark blue states. There's 11 of them, plus the District of Columbia that you can't see, who had all legalized that recreational / non-medical / adult use, whatever your term of preference is. Flash forward to just a few more years, 2023, that 11 has now become 24. Legalization is rapidly expanding. It's, I think, over 53% of US residents now live in a state with legalized use. And so anytime we're talking about cannabis and sort of how we can engage in prevention, we have to be thinking about that context that we're working within, where public opinion is leading more and more towards this happening. So there are a number of risk factors beyond the perceptions of harm that can lead to cannabis use. This slide here is just some of those examples. And a thing I actually want to note, right, is that when it comes to research around risk and protective factors, a lot of times we only actually have research on just generally for substance use. These are the risk factors, these are the protective factors. It's a bit more rare where we have research on, for this specific substance, these are the risk and protective factors. We have a ton of research for alcohol because it's sort of been such a big topic for so long. And we actually have a fair amount for cannabis just because it is such a relevant topic. But for some of the other substances we're talking about, there's just less research out there that's been identified. But as far as cannabis goes, a few of the ones that have been identified as specifically being risk factors for cannabis use are engaging in antisocial behaviors, perceiving that peers are using cannabis. That's a really important one. If people think that the people around them are using cannabis, that can further, whether or not they actually are, that can further lead to that normalization of the idea of using it and become more likely that they will. Another one is sort of parental attitudes towards cannabis use. If they're accepting of it, also normalizes. Conversely, sort of family conflict it can become another risk factor, where if there is a lot of conflict, sometimes youth can start using cannabis, or sometimes other substances, but again, we're specifically talking about cannabis here as sort of like a coping mechanism. But beyond that, we also have some more environmental factors. One example of that is sort of this, what I termed here, low policy enforcement. There are sanctions against cannabis use, even in states that legalize for adults, right? None of them legalize for those under 21, but it's becoming more and more rare that those sanctions are being enforced, which can further reduce the perceptions of harm that stem from use. Also, when in states where legalization does occur, the policies that are supposed to be in place to stop youth access aren't always being appropriately followed, like vendors not checking for ID the way they're supposed to, and which then also ties into that legalization issue, and so all we've been talking about related to that. So obviously, a lot more can be said about cannabis. Can do whole webinars on it, but that's sort of a overview of where things currently are. So yeah, that's where things are, Aaron.
Wow, that's a lot of information, and I think a topic that I have noticed a lot of interest in, and I'm very interested in as well. So thank you. And as we chat here, please feel free to drop in the chat or in the Q&A any of your thoughts as you're thinking about, what does this mean for you? Does this match what you're seeing? And how does this change your thinking? I two things really for me, Josh, that I want to know more about and I'm curious about is the impact of the increase in adult use. What can we draw from understanding if adults use is the largest population increasing, what does that mean for our youth and the risk factors associated with our community norms around marijuana and cannabis use?
Yeah, no, I mean, it's another good question, Aaron. Yeah,
It's a tough
so
one.
so adult use, and so the issue around it really illustrates like the importance of doing that prioritization of sort of what's going on in your community, because adult use, there's certainly a risk that can again further lead to normalization of use just in general, and sort of the further declines in perceptions of harm among youth. Youth might think, hey, if my parents are using this, why can't I? Kind of thing. So there definitely can be a risk of it having that impact. And so we need to think about, whether we want to be addressing adult use so that we can better address youth use. At the same time, again, we don't have usually the capacity to address everything. So if we don't see that sort of issue being as important, or if we don't think that's occurring in our community, maybe we don't address adult cannabis use because there's just other things that are, going on in the community that we need to better, that we need to be focusing more on. As I mentioned, we can't address everything, and so really thinking through that prioritization of needs is key.
Thank you. That's helpful. And then I think this is a question for the ages, and one that we will be asking ourselves for years. So I just put out there about thinking about what are the implications of this ongoing legalization debate, not just for use and risk factors, but for prevention as a whole. How does this debate, this ongoing debate, how does it impact prevention?
Yeah, so this is definitely one where that disclaimer about the views being of the presenter are key. But my personal view is basically legalization is going to keep happening, like it's been going on for a long time now. If you're in a state where it seems like legalization is unlikely because maybe the state legislature's against it or the governor's promised that they'll veto it, like if it seems like the status quo can hold, that's great. But if it seems like legalization will occur, or legalization's occurred, but like the development of regulations hasn't fully happened yet, I think it's really important for prevention to engage in that topic and try to, get involved in, advisory councils and boards, just to try to make sure that the policies and regulations are as stringent as they can be, because we want to at least have a seat at that table. Because if we are fully disengaged from it, it might end up even being worse than otherwise would be. Again, that doesn't mean support legalization, right? Like if you think you can stop it from happening, that's great. But just we see from the trend lines, it is just spreading more and more. Yeah.
No, and I think that's a great point to have. No matter where your state is in on the spectrum of change that's happening across the country, that prevention's engaged. Be there, be engaged, be part of the conversation. I think that's really helpful. And we have a couple of questions that I'm not sure we have time to dig all the way into, but I'm really interested in. We have one question about how can we use what we've learned about alcohol prevention efforts for cannabis prevention efforts. It seems like there might be some parallels as states legalize.
Yeah, I mean, two of the big ones. So with alcohol, there's been a few things. One, the policies we implemented were effective so long as they were fully enforced. So like there is a lot of focus, right, on educating that. Pretty much every retailer who serves alcohol or sells alcohol knows to check ID. Also, when people are driving under the influence of alcohol, if they're under 21, a lot of states, have like zero tolerance laws. So people better understand that there are like risks associated with it. There's also been, a lot of effective work done at making people understand the risks from alcohol use and that change in perceptions of harm. Right now, like we see with cannabis, the perceptions of harm are still going down. So it'll be really tough to sort of reverse that slide. It probably, not to say we should engage with that, but it might take time before we see results. But in the meantime, that's why I think that focus on engaging with policy is so important, to the extent we can, because with alcohol, those policy changes were just an enormous part of the decline.
Yeah. Thank you. And enforcement is such a key part of it. And I'm glad to hear you say that. I also think, it's that focus on risk factors, that staying really focused on risk factors. So many of these risk factors are shared across these substances and issues. I want to keep moving because we do some other substances that we want to dig into, and there are some questions that I think might take a little bit more thinking. So Josh, maybe we can respond to those in a follow-up response. But for now, I want to keep moving because I think we have some really interesting content to get into on stimulants and the changing trends in stimulant use.
Yeah, definitely. So when we talk about stimulants, we mostly are talking about methamphetamines and cocaine, but there are also prescription stimulant misuse issues as well. So this first slide here shows methamphetamine use. Note that it is past year rather than past month, And also note, that y-axis, the numbers are quite a bit lower than what we were talking about with alcohol and cannabis. But there is that significant upward trend. And also, obviously, when we're talking about methamphetamines, there are just enormous risks associated with it. So even if the use rates are low, it can still be a major cause of concern because of the impacts of use. And also, the fact that it's going up, and there's the risk that it will continue to go up. So this is what's going on nationally. So again, let's make that state comparison. And when we look at the states here, we can sort of see that they're kind of going all over the place. Now, part of the reason for that is we are talking about relatively low numbers here, especially at the state level. So the data is a bit noisier. It can bounce around and doesn't necessarily mean anything. But note that, looking across the entire timeline, rates are up in 3 states and basically flat in another 2. It's only 1 state that there does seem like there's an actual decline. So even though the numbers are kind of bouncy, in general, they seem to be going up. And in the more reliable national number, we definitely see that upward trend. So, if you're concerned about methamphetamine use in your state or want to learn more, you would definitely want to do your own needs assessment, which would be more robust than this data, right? Which is like a state subsample from national figures. So when we look at an age breakdown for methamphetamine use, there's some interesting stuff that pops up. First of all, you can see that nationally, vast majority of use is among those 26 and older. That seems to generally be the case for the states in the region. There are 2 states that aren't following that trend. But again, I don't know if that represents anything specific or if it's just a fact of how the data is a bit more unreliable. But that more reliable national data, not only does it show that most use is occurring among those 26 and older, it also shows that most initiations are among 26 and older. In other words, the people starting out with their methamphetamine use are people who are over 26. And obviously, a lot of times in prevention, a lot of our work is focusing on youth and young adults. It can be easier to address the risk and protective factors at younger ages. There's a lot more research about evidence-based strategies. But this is one of those examples, and there are others when you dive into data about the need for more prevention for adults, because it's adults that are starting the use. So it's a really important point to illustrate. I don't have in this presentation use data on cocaine. I'll just tell you that it's basically flat. It's a bit higher than the methamphetamine use, but it hasn't really changed in quite a while. I do have cocaine data as well as methamphetamine data on this slide, though, which are the stimulant-involved fatal overdoses for both the region and the nation, comparing 2017 to 2021, again being in that per 100,000 number. And these numbers are actually quite high compared to what we see in that use data. It can be a bit hard to see that when because it's hard to visualize a per 100,000 number. But to give you just one sense of what we mean by this, the methamphetamine national numbers for 2021, it's about 32,000 deaths. Like it's a big number of people, and it far actually outscopes what we see just in that use number. And this is why we really do care about stimulant misuse, even if the use data isn't that high yet. Yeah, Aaron.
I want to jump in and ask a question, because I don't want the slide to go by without asking this question.
Yeah.
Which is, these are big jumps.
Mm-hmm.
These aren't just big numbers, but they're big jumps. And if the stimulant use it's going up, but it didn't seem that it was going up that much. Why are we seeing this very big increase in overdose?
Yeah, so there's really 2 reasons, actually. One people might be more familiar with, which is fentanyl. Fentanyl shows up in a lot of substances, including non-opioids, and it's actually a really big risk when it's in non-opioids, because the people who are seeking out and consuming cocaine or methamphetamine might not have any history of opioid use. They might not have any tolerance for opioids, and fentanyl is, as we all know, extremely potent. So if it shows up, it can lead to that. those deaths. The other issue, though, is both cocaine and methamphetamine are also just on their own a lot more potent and pure than they used to be. And so if you do dive into the data and like exclude fentanyl deaths, which is the thing you can do if you use the CDC Wonder data source, those deaths are also increasing. So for instance, methamphetamine, the DEA tests, the drugs they seize. Back in like 2012, 2013, they estimated that the average methamphetamine sample was about 36% pure. In other words, about 2/3 of it were just filler substances, and about 1/3 of it was methamphetamine itself. In 2020, 96% of it was pure methamphetamine, and only about 4% was filler. So the substances themselves are just way stronger than they used to be. And people don't always know that. So
That's
yeah, a couple things going on there. Yeah.
That's really helpful. I also know that the number of pills tested by DEA, the percentage of pills tested by DEA that come in, 70% or 7 in 10 test positive for having lethal doses of fentanyl in them, not pills sold as fentanyl. So so this is really what we're looking at, is an increase in potency and an increase in polysubstance use, or unintentional polysubstance use, that's causing these overdoses. That's really useful context. I appreciate that. I'm going to let you keep going. I'm so sorry to interrupt.
Oh, definitely. All good. Yeah. So, for each of these substances now, I've been showing perception of great risk of harm. And all this data, comes from NISDA. Unfortunately, NISDA doesn't ask the survey question or doesn't report out the data of perceptions of harm around methamphetamine use. They only do for cocaine. So, I still decide to show it. Why not? And you can see that actually there are some declines there. I haven't seen any research as to why perceptions of risk from cocaine might have gone down, but it's understandably concerning that it is going down at all, because obviously cocaine on its own, has all sorts of risk factors. Cocaine has all sorts of risks stemming from it, all sorts of health impacts beyond the overdoses. It's a dangerous substance, and then there's this increased risk of overdose in recent years. So definitely concerning that the perception of harm might be declining there. As far as some other risk factors, and we're going to circle back to methamphetamine here. We do know some of them, but with methamphetamine, just as a bit of a side note, if you start digging into some of the academic research around it, you really need to be careful that you're looking at recent studies, because, as we all, well, maybe not all, but most people probably know, there was a past wave of methamphetamine use about like 2003 to 2009. It's when, for instance, pseudoephedrine became harder to obtain in stores because people were using that to make methamphetamine. And there were research around the risk factors for methamphetamine use back then, but we don't know to what extent those risk factors still hold true. For instance, back then there was a study finding that there was a risk of perceived benefits of use of methamphetamine among stay-at-home parents, thinking that methamphetamine would increase their energy levels to get their chores done. There hasn't been any new studies about that, though, so couldn't say whether that's still the case or not. So it's really important to be looking at more recent research rather than something that was conducted 20 years ago, because the world changes a lot. These factors here, though, are ones that are more recent, and a big one is engaging. Someone who currently uses heroin is at a very high risk of also using methamphetamine, and that's number's gone up. So in 2015, about a little over 8% of people currently using heroin also used methamphetamines. By 2019, that was 34%. So, a lot of risk there. The other risk factors we have here were identified through an analysis of basically of NISDA data, finding that these were associated with greater risk, but there hasn't been research yet on sort of the mechanisms as to why. We could probably guess, but I don't like guessing. So all I'll say is, it has been, people who do have past substance use of any sort, greater risk, likewise have family history of substance use or a history of criminal justice involvement, the lower educational attainment, lower annual income, as well as just methamphetamine being more widely available. And it's important, even if we don't know the mechanisms for why a risk factor is associated with substance use, so long as we know that the factor exists, we can still start to address it, because it can at least start to point us in the right direction of, who should we be partnering with, or, which populations we should be better targeting, better serving. But this is a topic where we do need to know more about why methamphetamine use has been increasing. And that's the data on stimulants that I have, Aaron.
Wow. Thank you so much, Josh. That's really helpful information. And I think one of the things and I'm just going to go back really quick so we can look at those additional risk factors. Because when I think about like, what does this mean for me in prevention? What does this mean for my work? I look at that list, especially around education and criminal justice. And I really think about, who are my partners? Am I working with and educating criminal justice? Am I talking about, really educating people on these risk factors, that there may be good partners to work with? So I just think that information for me, thinking about an increase in methamphetamine, if that's happening in my community, who am I talking to? Who am I educating about that? Because it might not fall in my bailiwick, but it might in criminal justice. So I think that's really interesting. I'm curious if other people have questions about that. I know I have one more question. I could just ask questions and talk about this all day, Josh.
Yeah.
We have talked about overdoses. So I do want to see, someone did ask about what's the data, the overdose data. Is that toxicology reports? Where's that data come from, or that information?
Yeah, so all of the death data that I've been talking about today, including like the alcohol-induced deaths, it all comes from this system called CDC Wonder. I forget exactly what Wonder stands for, but it's the CDC's system for reviewing data from the National Vital Statistics System, which is what states report their data into, and states collect their data in a lot of different ways from the medical examiners or coroners, again, varies by state, who exist in their state. And basically, it's just reporting out what the death certificates are saying. So in some state, so like if the medical examiner said methamphetamine was an underlying cause of death for this person's death, it shows up in these numbers. Hopefully, the medical examiner would have done a toxicology report before making that determination, but there's no guarantee that that's the case, because by the time we get the data, it's gone through multiple layers. And again, at the end of the day, it's whatever the people on the ground are reporting up on the death certificates. And so we kind of have to trust that they're doing, what they should be doing in terms of accuracy. So.
Great, that's really helpful. And there's a number of questions that are popping up in our Q&A, and I think I think maybe we can't get to them all, unfortunately, because some of them are pretty in-depth. And I know, I'm just trying to see if I can look at them quickly. What was the year range in the percentage of those using heroin who were also using meth that you mentioned earlier?
Yeah, so that data was a little bit earlier, because it
Okay.
was from a one-off study, but that range was from 2015 to 2019.
Oh, okay, great. So that 34 was 2019. Okay,
Yeah.
so a little earlier, but that is helpful context.
Mm-hmm.
Okay, and then let me see, let me just check. I think we have one question about ways to find out how many overdoses are not being reported. Is there any sort of proxy data? Is there anything that we can look at to understand? Maybe a better place to start with this is, do we suspect that overdoses are underreported? And if so, why?
Yeah, well, certainly they are, because obviously, right, all the data I've been pointing out are the fatal overdoses, because if there's a death, eventually people find out and it gets all it gets reported out. But if it's non-fatal, and so
Okay.
probably the fatal numbers are pretty accurate. There's always a risk of some one-off medical examiners or coroners, like doing their own thing. There's definitely been anecdotal reports, for instance, of examiners like not reporting a death as an overdose out of respect of the family because they know the relative. So there's always the chance there's a few numbers here or there that are off, but not by a huge amount. But in terms of non-fatal overdoses, we really don't have any good idea of how many there are. I mean, we can look at stuff like how many successful administrations of naloxone there are, but that's and like we can see how that changes over time, but that's not really an effective proxy measure.
Yeah, even that we know is low and poorly reported. So it's interesting, and I'm glad that this question came up because I think it's important to remember that when we are talking about overdose data, we are talking about deaths. We're not just talking about instances of overdoses or non-fatal overdoses, but these are deaths. And so that's important to kind of keep in mind, one, in kind of the severity, but I also think also because it is not a full picture of what's happening. So I think that's really helpful. I want to keep going because I know the next substance we're going to talk about, people are probably interested and anxious to know how the trends are changing here for a bazillion reasons. So I am going to take us to the next section where we're going to talk about opioids.
Yeah, so we've talked a little bit about fentanyl already, but let's really dive into the overall topic of opioids. And I've actually flipped the order of slides from how the previous sections have gone. So first of all, I have that age breakdown. And the reason why I've put this first is because, again, we've been using this National Survey on Drug Use and Health for all of our use data. And 2021 was actually the first year that they reported out a measure of all opioid misuse. It used to be that they had a measure for prescription opioid misuse, as well as a separate measure about heroin use, but they didn't ask anything about fentanyl use, partially because the issues around unintentional use. So we never had a number of just overall opioid misuse until 2021. So I can't show a trend line for that specifically, but since it's sort of the overall topic, wanted to start here. And so you can see for the nation as well as for the states, sort of what the overall rate of past year opioid misuse is, as well as the years, age ranges of youth, young adults, and adults. Now, as we'll be showing over the next few slides, generally opioid misuse has been declining, at least all the different separate type measures we have been showing a decline. But obviously because of the risks of misuse, it still, of course, remains a really important topic for us. And even though we don't have any demographic data in this presentation beyond this age ranges, it really is important to find out what is going on among specific demographics in your community, because sometimes there are important changes that can be going on. So, for instance, nationally, at least, among Native Hawaiians and Pacific Islanders, there's actually been, in contrast to a lot of groups, a very big increase in opioid misuse from 2017 to 2022. And in fact, their overall rate of misuse is about 2.5 times higher than the next highest group at this point. So it's really important when we'll talk about any substance, but particularly ones like this, to really dig into the data and find out what's going on among specific populations. Now, as far as trend lines, I do have a few to show. First of all, right, we have prescription pain reliever, meaning opioids, but NISDA says pain reliever misuse. And what we do see in the data, and I think most people know at this point, is there actually has been a pretty big decline in prescription opioid misuse. And it actually dates all the way back to 2010, when OxyContin changed their formula to make it harder to misuse. That was actually a triggering point for just an ongoing, and I mean, there's other things that have been going on since then as well for this to happen, but this ongoing decline in prescription pain reliever misuse. It doesn't mean, of course, that the issue is gone, because again, we don't have data going back to like the 90s, but, or at least we're not showing it here, but we're still way above where we were before the opioid epidemic began. So there's a lot more work that needs to get done. And also, right, prescription pain relievers are only one part of the epidemic. But first of all, on this next slide, I want to show the state data again, and you can see all the states following that national trend line, and that's something we see in almost every state that I've ever looked at data for is showing similar trends as the nation, that this overall scope, at least, of prescription opioid misuse is going down. I don't have a chart here of heroin use. I can tell you that it did go up, especially in the early 2010s, like right around the time that prescription opioid misuse was going down, heroin use was going up. And there is research showing that there was a substitution effect going on, where some number of people did directly switch from prescription opioids to heroin because it became more difficult to obtain prescription opioids, or it became more difficult to misuse them. So that always speaks to sort of needing to figure out the potential unintended consequences of policy changes. So just a bit of a side note there. But of course, when we're talking about opioids, a lot of times a lot of the reason we talk about them still is the overdoses, right? And a lot of them are stemming from fentanyl. This chart here shows those national numbers. Again, it can be hard to visualize when we're talking about per 100,000, which I have here, so I can make the state comparison on the next slide. But to put some raw numbers to this, in 2017, nationally, there were 31,335 fatal fentanyl-involved overdoses. 2021, there were 70,601. The provisional number for 2022 is 74,225, so it's still going up. And also, just as a point of comparison, in 2013, which was the last year, 2014 is really when fentanyl use became more widespread. So 2013, the last year before that widespread use, this fatal overdose number was 3,105.
Wow.
So yeah, a big number, but compare 3,000 to 70,000. And also you can see it's not it's getting worse over time, especially during COVID. But it hasn't gone down, as I said, in the provisional 2022 data or the provisional 2023 data. It still is elevated issue that we really need to better get a handle on. And when we look at the state data, we can see it mostly follows the same trend lines. There is one state that does look a little bit different, which is actually Ohio. You can see there was a decline from 2017 to 2018, but also it was so far above the other states before then, that partially because they were actually dealing with a major issue of carfentanil, which is a even more potent form of fentanyl. And then they were able to implement some changes that started to get the carfentanil under control, but fentanyl remained a major issue. And also, Ohio does border both Pennsylvania and West Virginia, who have high numbers as well. And it is always important to sort of know what's going on with our neighbors, because obviously, state borders are, they're not really, I mean, they're borders in terms of policy changes, right? But trends easily cross borders. And I can tell you, in West Virginia, the fentanyl-involved fatal overdose number for 2021 would not even be on this chart at all. It was 66.7. And of course, there is that Ohio, West Virginia border. So regional impacts can definitely impact states. But you can see for all states, there's been some pretty major increases. Now, we don't have perceptions of harm data for fentanyl. We do have them for heroin. If you pay attention to the x-axis, you can see it actually goes all the way up to 90%. So it is a very high number. But again, same as with cocaine, for some reason, there actually has been a slight decline in the perception of harm of heroin use. Again, not sure why that might be the case, but it is certainly very concerning. Some of it might be because we talk less about heroin and talk more about fentanyl, but an awful lot of the time, heroin contains fentanyl. So people should perceive a great risk of harm from heroin. So this is definitely something we want to stay on top of why. And again, the number is still very high, right? It's over 80% almost everywhere, but the fact that it declined at all is certainly of concern. And we do have, again, some additional risk factors. First of all, just talking about opioid misuse of all kinds. Some of the common risk factors are having a past or current substance use. Obviously, that can lead to other forms of substance use. So that's a sort of a risk factor for a lot of substances that we see. Having a mental health disorder, having a high level of pain or chronic pain. With opioids, there really is that issue of self-medication and people sort of using opioids because they potentially don't have access to adequate medical care to get the correct, pain relief. Experiencing discrimination. This is one that probably is a risk factor for most substances. I have seen research of it for substance use generally, and have also seen it for opioid use specifically. So that's why I wanted to call it out here. There is research showing, right, that if you experience discrimination, it can increase your stress and anxiety in a lot of ways, and those are associated with increased risk of substance use. And there are studies showing specifically that, yeah, experiencing discrimination does lead to increased risk of opioid misuse. And so when we're talking about, in new prevention strategies, one that maybe if you haven't been thinking about already, would be trying to better address discrimination and racism and so forth. Also, another risk factor, and one specifically for prescription opioid misuse, is having a prescription for either high dose, prolonged duration, or extended release opioids. That's part of the reason why anytime we're talking about strategies for preventing prescription opioid misuse, we talk about prescriber education and getting prescribers to not be issuing unnecessarily risky prescriptions. We also have some research on heroin use risk factors specifically. A few that have been identified are first of all, someone who, if they have opioid pain reliever misuse or dependency, there is that risk of either substitution or just sort of gatewaying to heroin use. A history of polysubstance use is another risk factor. Also, that history of criminal justice involvement and history of child abuse are a couple others that have been identified in the research. And that's what we have on opioids, Aaron.
Wow, that was a lot. Thank you. And I think, there's a number of questions kind of in the chat relating to how our perceptions of harm change or may change as there's an increased understanding of fentanyl in our drug supply in general. So I don't know if that's something we've started to see or we suspect we might see as there's more education and more publicity around the increase of fentanyl in all of our substances, in the whole drug supply.
Yeah, I think that definitely important topic. It's certainly one that I think there have been efforts to better educate. Sometimes just stemming not even prevention, but straight up harm reduction. Some states or cities have issued like alert systems to let people know that, hey, we're seeing a lot of fentanyl overdoses right now. Check your substances. And there's things like the fentanyl test strips, which are legal in, last I saw, I think it was 24 states, maybe. So there is that. There are those sort of efforts. I haven't seen any specific research on whether, because there's a better understanding of fentanyl, maybe that leads to people not perceiving other substances as being as risky. Again, if that is the case, though, it's something we'd want to counter, because setting aside fentanyl at all entirely, like heroin on its own, still pretty darn bad for you. So yeah.
Pretty darn bad. That's a quote I'm going to take to the bank. Pretty darn bad. So speaking of kind of this unintentional fentanyl use, right? So this concern that the drug supply has a lot of fentanyl mixed into all the substances we're seeing. What does that mean for prevention? I mean, we know what good prevention practice is, but when we're talking about something like fentanyl that's unintentionally consumed by someone who thinks they're taking methamphetamine, or thinks they're taking something else that, but ultimately there's fentanyl mixed in. How as preventionists do we address that?
Yeah, no, it is certainly a tough one. I mean, part of it is sort of has led to, right, an increased role of prevention, or prevention playing an increased role in harm reduction, being more involved in expanding access to naloxone, including to populations that don't actually think that they're using opioids, like trying to get naloxone to people who are stimulant users because they're at a risk as well. But it also means that, like, if we're concerned about fentanyl use, it can be hard to, we can't always treat it as a traditional substance. Like, we don't net, like, for instance, we wouldn't necessarily, I mean, we probably still want to do educational campaigns around fentanyl, but the issue might not be people not perceiving fentanyl as being risky, but the issue is people don't even know that there's fentanyl in their substances. And so maybe a better campaign than the risk of fentanyl is a campaign around the risk that fentanyl is in other substances, or a campaign focused on, assuming it's legal in your state, around fentanyl testing strips. It really, this is part of the reason why until 2021, NISDA didn't even try to collect data on fentanyl use, because we don't know how high unintentional use rates are, because sort of by definition, if people don't know they're using it, they can't report they're using it. But every indication is that most fentanyl use is unintentional. And so because people aren't deliberately seeking out the fentanyl, a lot of things that we might do in prevention suddenly aren't necessarily as relevant, because people don't even think that they want to be taking fentanyl. It just sort of comes up. So we have to, yeah.
Absolutely. That's really, it's a fascinating and difficult topic for prevention as we wade into these waters. So I appreciate your thoughtfulness on that. And there are a number of questions that I'm seeing come up about harm reduction and understanding unintentional fentanyl. And there are people who, Catherine says, who are actively seeking out fentanyl. We do see that. That is, it's not all unintended use. But some of these questions that are pretty big questions about getting into harm reduction, I don't think we have time to do that right now. But Josh and I will take a look and see if there's any of them we can address. If we can address them, we'll try to do that in writing. If we can't, we'll let you know that that's just we don't have the answers to those questions. Unfortunately, we don't have the answers to all the questions. But I do, because I think this next section is also interesting and important. I want to move and take us to a discussion on other drugs. So there are other drugs than the ones we've just covered, and get a feel from you, Josh, about what's happening there.
Yeah, so just to take a few minutes here, because I do see where we are on time. And also there's just less data to talk about with these substances, but wanted to call out a few sort of less heard of issues that are going on. One is actually issues around hallucinogens, which probably most people have heard of hallucinogens. It's sort of been just a substance that's been going on in the background since, well, the 60s or even earlier. But something we actually see in the data has been a pretty dramatic increase in hallucinogen use, specifically non-LSD hallucinogen use over the past several years. In fact, as you can see on the slide there, among younger adults, like 19 to 30, non-LSD hallucinogen use has actually more than doubled from 2018 to 2021. We also see that, among sort of a slightly older age range at 35 to 50-year-olds, past year hallucinogen use actually reached its all-time high in 2022. And with hallucinogens, right, there is a lot of, sort of environmental context, right, to be aware of. There is starting to be more research about the potential, medical benefits of some forms of hallucinogen use. There's actually legalization to decriminalize hallucinogens in at least 22 states right now. So that may be having an impact on perceptions of harm, just like with cannabis, although we don't have data on that. But the thing is, right, even if hallucinogens do have some legitimate medical use, it doesn't mean that we shouldn't be concerned with misuse. Like prescription opioids have legitimate medical uses, but obviously we're concerned about the misuse there. And so when we see hallucinogen use increasing the way it is, and hallucinogens, even though they generally don't cause overdoses, can cause a lot of other serious health concerns, it is a potential topic of concern. Certainly something we at least want to be looking at.
Mhm.
So wanted to call that one out. And then very briefly, wanted to call out three other substances that really are just showing up in the past year or two. Xylazine, tienpitin, I think I said that one right, and nitazines. Xylazine is maybe the most commonly heard of these three. If you haven't heard of it, it's fine. It's only starting to show up as an issue in most states. It's a non-controlled veterinary sedative. So in other words, it's unrestricted access. You can buy it online, and it does have legit uses in veterinary medicine. It's also not an opioid, but over the past few years, it has started getting added to opioids because there's some chemical interactions that can happen that can lead to so xylazine increasing the length and intensity of an opioid high. And that's a concern because xylazine both increases the risk of an overdose occurring and also can cause a lot of other negative health concerns. The most well known at this point are the pretty big skin wounds that can show up on people using xylazine. And the numbers are increasing. I think in 2021 there were over 3,000 fatal overdoses that involved xylazine. And also want to note that right now, the sort of epicenter of xylazine use in the United States is in Philadelphia, and it is spreading outwards from there. And so when we talk about the Great Lakes region, it's not that far from Philadelphia. And actually, there's this really great chart you can find from the DEA showing overdose data by HHS region and sort of how it's expanding outwards from the region that Philadelphia is in. So definitely a thing we need to pay attention to and sort of is an issue that interacts with or even is just part of the opioid epidemic. Tienpitin is a substance that's legal at the federal level, but it hasn't been approved for any medical use by the FDA. In some other countries, it actually has been approved as an antidepressant, although some of those countries have started rescinding that approval in recent years because of the negative health effects of it. And it's actually banned in 9 states at this point, including Indiana and Ohio, because its effects can mimic heroin if you take large enough doses of it. And actually, its nickname sometimes or street name is gas station heroin because you can just buy it at a lot of gas stations and it can have negative effects. The numbers still are pretty low, over this 5-year range, which is actually several years ago. There were about 200 cases of poisonings reported. We don't have specific overdose data on it. So might not be the biggest issue, but definitely something we want to be keeping an eye on. It's something that's been mentioned more recently in the past couple of years. And then we have nitazines, which are a synthetic opioid that actually has existed since the 1950s, but no one really thought to start misusing it until very recently. Its first known case of misuse actually was in 2019 in the Great Lakes region. Actually, it is commonly mixed into heroin or fentanyl, although sometimes it is, falsely marketed as like oxycodone or something. And the issue about nitazine is that it is extraordinarily potent, up to 43 times more potent than fentanyl even. So even if the use rates are low, it's just enormous risk of harm for people who do use it. It has been known to be involved in at least 200 fatal overdoses over the past couple of years. And it is something really to keep an eye on. And also the DEA has so far identified new sort of supply chains of nitazine. And 2 of those 3 were in Minnesota and Illinois. So seems like right now the Great Lakes region actually might be, even though it's not a huge issue yet, Great Lakes might actually be the epicenter of it. So just 3 substances here to keep an eye on and pay attention to if they're starting to crop up.
Yeah.
So
Well, thank you so much for covering that. It's all really interesting. And I think one of the things that I'm seeing here and hearing is that we have to keep our eyes and ears open about these things. But ultimately what we're really looking at is from a prevention landscape, a prevention lens is focusing on those risk and protective factors that we know can support non-use or reduce initiation of use of all substances. So it's really important that we know, though, about these things on the horizon. And so I'm wondering if you can talk a little bit about the kind of the takeaways we should be thinking about.
Yeah. So we can just move things forward. So first of all, right, looking at the data, what we do see, right, are that the biggest increasing trends in the Great Lakes region, the Midwest region, is that increase in cannabis use and the issue around fentanyl involved overdoses. It doesn't necessarily mean those are the most important issues in your state or your community, but as a starting point for like doing a needs assessment, because we do see the regional data, these are sort of the most rapidly increasing issues. But regardless of what the key issues you identify in your community are or your state are, it's really important to understand what the causes are behind those trends, right? Because the work we do in prevention is addressing causes. We work on addressing the risk factors and addressing the protective factors. And as we talked about at the beginning, sometimes that means doing changes in the work we're doing, but sometimes it means keeping on doing what we're already doing, because even if there's a new trend, if it's stemming from the same causes as the trends you already were addressing, well, keep on addressing those trends. Like maybe you have to make a slight change, maybe there's a new population more at risk, but sometimes what we're already doing is the best thing to be doing. So it's really important to think through that and really engage in a strategic planning process to figure that out.
Well, thank you, Josh. You covered so much, and I appreciate it so much. And so, when you do receive the slides, there's information on how to reach out to Josh and Carnevale and Associates, who has lots of great information. There's also a full references page that has all the information about where Josh's data came from. I know we did not get to a ton of questions, so we will try to respond to those as we can. I'm going to turn it over and to Chris Gabrielson to tell us a little bit about what's coming up in the Great Lakes.
Great. Thank you so much. Josh, I greatly appreciate all the information you pulled together, and Aaron for facilitating it. Couple of things coming up. One is that applications close tomorrow for the NIATEX Change Leader Academy for Prevention Professionals. So if you've been intending to apply, do it now before you regret it. Next, we have our next session of Deep Dive into Prevention Ethics on the first Thursday coming up next month. Substance use and other risk factors for gun violence, prevention and intervention strategies, coming up on March 12th with Mark Sanders. On March 20th, prevention works and a call to action. So as we look at the data, we're going to talk about more data, this one, of looking at what does data tell us about how we've been effective in prevention, and how can you use that information to really make a case for prevention? So I highly recommend you attend that. That's with Kevin Haggerty with the University of Washington Social Development Research Group. Trending now on social media. Many of you have been asking for another training on social media. Be sure to sign up for this one. It's on March 28th. Few more. We have the Sustainability Planning Intensive Training course. If you're wanting to dig deep into sustainability and how to create a sustainable prevention effort in your community, be sure to apply to attend that course. We serve too, increasing resiliency in military connected youth. I wanted to pause on this because not many people have signed up. And I think that's because there's the false understanding that if you are not near a military base, that you don't have very many military connected youth in your community. Kentucky did a study on this, and they had about 40% of the youth across the state were military connected youth. So if you are thinking you don't have them in your community, I highly recommend you sign up for this webinar so that you learn more about who those kids are and what you can be doing with them in terms of increasing their resiliency. April 18th, brainstorming the future using generative artificial intelligence, AI, in your substance misuse prevention work. It's going to be fascinating webinar with Brian Klaas from Johns Hopkins. And strategies for prevention substance misuse in older adults. Many people have been asking for more information about what we do with older adults. Be sure to sign up for that on April 25th with Chuck Leapguard. If you haven't already, be sure to like and follow us on LinkedIn and Facebook. We post every day with information that we hope that you find helpful in your substance misuse prevention work. So be sure to do that if you haven't already. And otherwise, as Rebecca shared before, please complete the GIPRA form once we close out this webinar. Thank you again, everyone, for being here. Thank you, Josh and Aaron. Thank you, Rebecca, for being on the back end and making sure this all comes to fruition. I hope everybody has a fantastic rest of your day. Bye-bye, everyone.